To me, AXERA is probably going to be the future of access closure. This device offers both.
The concept was absolutely brilliant.
Numerous complications can occur during closure of the femoral artery.
Complications could be retroperitoneal bleed, or it could be a pseudoaneurysm formation.
Without good access techniques early on, it's irrelevant what closure device you use or how you close the patient. The poor access technique is the beginning of all complications and groin complications.
The patient is going to remember the groin and the complication that went with it rather than the great success you had with the intervention.
With comparison to vascular closure devices, the AXERA has several benefits. The most important of which is there are no foreign objects left behind. A foreign object acts as a nidus for infection. They can also act as a nidus for inflammation, increase pain for the patient, and no patient, no matter what their age, wants to have a lump in their groin.
So to explain how this self-sealing arteriotomy works, it's basically an ultra-low angle arteriotomy, which provides hemostasis with tissue and tissue overlap.
Not only is this access, but once you obtain access, then you don't have to worry about closure. It's already done. The patient's going to have easy ambulation times. All of our patients were ambulated within 2 hours. They were sitting up within 30 minutes. There was no lump left behind in their groin. There was no peri-closure ooze leading to ecchymosis. The patients had less inflammation. They had less pain. They spent less time being compressed on their groin and were able to sit up quickly after and eat, so they were happy.
Some patients may ask, what about radial approach that has gained some popularity? I truly feel that you're getting all the benefits of that you would get with radial with this, namely that the patients have the comfort of getting up and with less complications without having to deal with all the extra adjustments that you may need to have when you're doing the radial approach. I truly feel that everyone benefits from this. It's very simple to use. It takes less than 1 minute. And of course, it provides a secure closure so that I know that this patient is not going to be bleeding or having more hematoma issues once they're out to the medical observation unit.
Once the patient is completed, take the patient off the cath lab table into the bed that they're going to rest in, and you get them out of the lab. The turnover is much more rapid. Manual compression can be done in the holding area with the removal of the sheath, thereby freeing up staff in the cath lab and freeing up the cath lab itself.
They can basically set up at 45-degree angle within 15 to 30 minutes, and they can ambulate within 1 hour.
Patients were able to sit up in 30 minutes, so if they were able to eat, they could at that time. Patients were also allowed to ambulate in anywhere from 1.5 to 2 hours, generally 2 hours on average in my lab. And the patients didn't have complications where they came back in secondary to bleeds, hematomas, or other problems. Now, I will tell any interventional cardiologist that it does not matter if you save the patient's life. It doesn't matter what you do in their coronaries, they cannot see that. All they can see is their groin. So if you mess up their groin, you've messed up.
So good closure starts with a good access. So it's very important to do the right thing right at the beginning and get the best access possible.
1,000 devices later, I'm still using AXERA.
And I hope to see more of this approach and technology to be used nationwide so that all patients can have the benefits of this device that I have noted in my patients.